Hi everyone, I wanted to make a video slash PowerPoint for you on our arrhythmias and our antiarrhythmic drugs, also known as AADs. You can see the chapters that we're referring to, both Arcangelo and McCants. So our book classifies our drugs in terms of which channels they block. And it's not just our book, it's just a common scoring classifying system. So to begin a little bit with the conduction system, which begins over on the left with the SA node, which is known as the heart's pacemaker, and it has its own independent ability to uh, generate an impulse, which then travels to the AV node and then down in between the septum via the bundle of His along to the lateral ventricle wall leading to contraction. And then you see kind of in the diagram on the right the pathway from SA to both atria to AV down to the bundle branches and to the fibers leading to contraction. Now, what allows all this to happen? Well, it's the fact that the cardiac cells have electrical polarity. And we have to go back to our very first unit in McCants on action potential propagation. So the inside of our cell is more negatively charged than the outside. And why is that so? It's because of the difference in ions between the inside and the outside of the cell. Where is there more sodium and where is there more potassium? Is sodium higher inside or outside of the cell? Just think about it for a minute. Think of your lab values. We know sodium predominates the extracellular fluid, and potassium is higher intracellularly. And so the picture on the right then kind of shows what our sodium-potassium pump does. And this is kind of what leads to our action potential. It's because cells, their walls are semi-permeable. And so some of the ions are always kind of diffusing. You can see the little diffusion channels there. And the middle pump there on the right, where it shows 3 sodium out for 2 potassium in, that's what the sodium pump does. It keeps that sodium out, keeps that potassium in, even though the ions are kind of naturally leaking. And so the chloride, which are negative ions, they tend to build up in the inside of the cell wall because of polarity, and that's what kind of gives the cell membrane its voltage. Okay, so our next slide here just is a broader picture showing where the SA node is, and then it shows that current kind of spinning throughout the heart, and then it shows the corresponding waves of the action potential in a contractile cell. So just kind of a visual for you. So let's talk a little bit about the movement of the impulse. So the cells of the heart have certain qualities that make them particularly able to generate a potential and electricity called excitation. They're excitable cells. They also have automaticity, which means they can depolarize spontaneously. Now, this is an important thing to remember because part of the patho of a cardiac arrhythmia is disorders in automaticity, where like a random cell can just start depolarizing on its own, leading to an aberrant beat. But all things considered, normally things go well. We go from the SA to the AV, down the bundle, and out. Okay, so cells are excitable, and that means their membrane potential changes when there is a stimulus. Now, the resting membrane potential of a cardiac cell is negative 96 millivolts. That's called the resting potential, and remember it's caused by the difference between the ions on the inside and the outside of the cell. Now remember that sodium-potassium pump, that uses energy, that uses ATP. It's kind of like the cell's workhorse. So that's something else to just kind of keep in mind. Okay, Then what happens? So a muscle cell gets a stimulus, and that stimulus is a greater stimulus than the cell's resting potential. So all of a sudden, it becomes more permeable to sodium, which changes the charge of the cell's membrane. It goes up. That is an action potential, which is a rapid change in resting membrane potential. That's just kind of something you need to memorize. It's just we've got these cells that have a potential, and that means they can do electrical stuff. They have electrical potential as a result of ions that move in and out of the cell. Okay? So you've got cardiac cells that have the potential for electricity. They hang around with a voltage of negative 96, but then something happens that changes the balance of those ions, and then when there's a rapid enough change, we've exerted a larger potential called action potential. There's something happening. Sodium moves in, and that potential kind of moves forward. And this is what we call depolarization. And then that signal is going to kind of move from cell to cell. So these are the ions that impact the rate. Now, these ions are going to look kind of familiar to you because there's also drug classes that act specifically on them. So we've got potassium channels, and that's kind of is what controls the resting state when it's not contracting. So think about that very first picture of the sodium-potassium pump. So potassium is a higher concentration on the inside, and that's what kind of just keeps the cell resting. Potassium's in there minding its own business. Then you have sodium channels. That's what changes the cell's permeability to sodium changes rapidly, and that's what leads to the initial depolarization in contractile tissue. Then you got calcium channels that do two different things. So you can see there's slow response tissue in the heart. There's calcium channels there that make the heart contract, and they determine the rate. Then we've also got calcium channels that cause contraction in fast response tissue. The most important point is here to look at the potassium, sodium, calcium channels. We got drugs that hit all of those. This is a picture from McCants, and this really just kind of shows you the basic action potential. And in order for there to be kind of the lub-dub of the heart, you've got to have that wave of current moving across the whole heart. So when the ventricle has its depolarization, you can see the SA nodes kind of in a resting state, and the atria have already kind of contracted. Another picture from McCants. What I'm doing here is kind of connecting for you the nodes of the heart, the EKG, and the waves of the EKG, something to just kind of spend some time with. All right, what this does is this actually shows you in terms of the ion activity where they're moving in and out, and it will help you also determine what's going on with your drugs. So as you can see, your resting state is stage 4. Potassium's kind of the one there. We're at negative 96, and then something happens. So we get an action potential. And so that cell has gone from negative 96 to 0. Like, that is a huge change. A whole bunch of sodium has rushed in through those channels to bring up that wave up to that peak in phase 1, and now mind you, these are all in like milliseconds, okay? But then phase 1, calcium and chloride go out kind of transiently. Potassium and chloride go out. Phase 2, calcium goes in, potassium is still out. And you can kind of see that there's a little separation in the calcium there that just kind of remember the fast and the slow contractile tissue. So that's kind of happening there. Then in phase 3, we still have some potassium out, but it's starting to slowly go back in. And then by phase 4, we've got all the potassium back in, the sodium is out, and we're back to our resting potential. This kind of shows you where our antiarrhythmic drugs work relative to the action potential. This also shows you the permeability of the cells. So if you start on the left, you can see Now this one uses a negative 85, but I've kind of seen it both ways between negative 85 and negative 96. Be that as it may, the important point here is that potassium being in, sodium being out is what's keeping that negative membrane potential. Potassium rushing out and sodium rushing in is what changes it. Then you get some calcium. And then it shows you where all group 1 drugs kind of work on sodium. And you can see where that's going to be a pretty potent drug because sodium is kind of what makes a difference in an arrhythmia, sodium rushing in. Another picture of a very similar thing, kind of connecting the sodium and the calcium movement to the wave pattern. It's showing ATP usage to pump sodium out and potassium in and vice versa, which is why when a person is in acidosis or shock and our AT pump kind of gets taken out of the picture, we have problems. This is a picture from your book. Again, it's just showing you a written out form of what the phases are doing so that you can kind of connect all those. Now, a bit on the types of arrhythmias we have. We've got the supraventricular, which, if you think back to our picture, they're above the ventricles. So they're above that. They can either be slow or fast, tachy or brady. We can have a nodal arrhythmia, which is going to start right at the AV node. That usually means the SA node isn't connected or something's wrong with the SA node. Then you can have a ventricular arrhythmia, which means the ventricle has kind of taken over the driver's seat of the heart's rhythm. An example of some of the supraventricular arrhythmias, atrial fib and flutter are here. Picture of some of the junctional arrhythmias, just so you kind of have a list, and a slide with a listing of the ventricular arrhythmias. Now, here's a question for you, if you were paying attention. Your patient has torsade de pointes. What category would this be? Supra, junctional, ventricular? If you were paying any attention, you know that that's ventricular. And that's a form of VTAC associated with long QT. And that's why we monitor and watch long QTs, because it can kind of dissociate into VTAC. And some of our neurologic drugs do this. Okay, here's our causes. Remember, phase 4 depolarization, that's when we're getting down to negative 96. So there can be a defect there. We could also have increased automaticity. Remember, that's the ability of a cell to kind of generate its own impulse. The SA node and catecholamines. Remember, catecholamines are your adrenaline. SA node's very sensitive to input from that, so there can be an increased catecholamines. We can have a conduction deficit or a reentry phenomenon in which the typical depolarization wave does not get into a hyperpolarized state, and the impulse just is indefinitely propagated. So here are some of our causes. You can study these. The thyroid can lead to this. Electrolyte disturbances, that's when we see either a low or a high potassium rate. Digitoxicity can, caffeine, alphenol, anxiety can do this. So here's our summary slide for you. The point here is we want to search for a reversible cause. That's our first step, but then we also have to get that rate controlled. Again, here are our classifications, and now that we've kind of reviewed the channels, it should make a little more sense. Here's our goals. We want to relieve the episode, we want to reestablish sinus when possible, and then long-term we want to prevent further episodes. Here's what we're going to monitor. We're going to monitor where's that impulse coming from. How is the SA node doing relative to the AV node? What's the time interval? And then we're going to look at the heart rate within the normal range for age. Now here are our classes. These are classified by the rate of sodium channel dissociation or blocking. Remember, sodium is where we get the big bang for our buck in terms of depolarization. So 1A is an intermediate onset and intermediate offset. 1B is a fast onset and offset. 1C is a slow onset and offset. So kind of, depending on what rate that person has, what arrhythmia, is which med is chosen. Our beta blockers are a class 2 antiarrhythmic. We use them for supraventricular and ventricular. What they do is they slow AV and SA conduction by blocking those receptor sites. They decrease automaticity and they prolong that refractory period. There is a list for you of some of them. Class 3 acts on the potassium channel. So class 2 isn't so much a channel. Those are our beta blockers. That's going to be more blocking off sympathetic stimulation, which increases it. So by blocking it, we're going to slow it down. Here we're targeting the potassium channel. Now, amiodarone isn't a pure potassium. It has some effect on the sodium and a little bit of effect on calcium. So it's pretty potent. It's administered as a prodrug. Well, it's administered, it's a prodrug. And has a really crazy long half-life. Its metabolite has a half-life anywhere from 14 to 75 days. Here's a list of some other ones. And sotalol, being an allol, also has some non-selective beta-blocking properties. We know our calcium channel blockers. Remember, there's two kinds. The non-dihydropyridine, which is our diltiazem and verapamil. Our dihydropyridines, which is amlodipine, nifedipine, those are not so much used as a antiarrhythmic drug. Those are more for hypertension. So these act on the calcium channel, obviously. They slow the velocity, they decrease the automaticity. They just kind of dial it down. We've also got adenosine, which works on potassium and calcium, decreases depolarization and inhibits automaticity. Really short half-life, as you can see. So we kind of have some familiar themes here. We have decreasing automaticity, decreasing depolarization, slowing conduction, just everything you would want an antiarrhythmic to do. These were pictures that were also in our class PowerPoint, but it shows you specifically the impact of the calcium channel blockers, particularly on the heart. Here's a picture of our beta blockers. And that, my friends, is the end of our PowerPoint. However, I do have one more thing to show you, and you're doing much better on your APA with Archangelo because most of the time you're going to be quoting a chapter, and so you want to make sure you have the author name for the chapter and the title of the chapter, and then you have in the book, and then you list the editors, and then you italicize the title of the book. So whenever you're quoting a chapter from a book, you cite the authors in the chapter, and then the book, and then you have to put the edition and the page numbers, as well as the city and the publisher. Thank you very much.